We want to move now to the next speaker, who's Dr. Charles Shaw-Smith, who is a consultant in clinic genetics. It takes 9 months to make a baby, a human, and perhaps it's no surprise that the complexity of making a human sometimes goes wrong. Nature sometimes goes wrong. And I hope Dr. Charles Shaw-Smith will provide us some interesting insight, both for myself and indeed for you, on the complexity of what is involved in normal foregut and abnormal foregut development, and perhaps the genes are the main master players involved in this process. So, Charles, it's a pleasure to welcome you. Thank you.
Thank you very much, Professor Lustig. It's a pleasure to be here. I'd like to thank the TOFS committee for inviting me to speak, to continue my association with TOFS, which goes back a few years now. I'm sure every time I come, I see more familiar faces, which is nice. So I'm going to just give an outline of what I'm going to talk about first. I'm going to talk about the causes of TOF. I'm going to say a little bit about the early development of the trachea and esophagus, just to make a particular point about that. Say a little bit about VACTERL, a little bit about family studies and recurrence risk. And then I'm going to talk about some recent work that I've been doing in collaboration with TOFS, which I'm quite excited about, actually, and talk about some future plans to do with that. So I think it's such a major thing that you're asked to deal with when your baby is born and diagnosed with esophageal atresia or Tracheo-Oesophageal fistula. And it takes quite a while for the dust from all of that to settle. But then often you're left with the question of why. And to be honest, we have some answers, but for the broad majority of children with this condition, we're still not very good at providing an explanation for why it happened. One thing I feel very passionately about is that it doesn't just happen. There has to be a reason. You know, we have evolved as humans over millions of years for the design process to work well. And in the majority of cases, it does work well. And when it doesn't work, it doesn't go wrong just, as I say, for no reason. There is an underlying explanation. So this has been driving me for a long time, really, to try and understand what the causes are. And it's taken me in some quite unexpected directions. So, like I say, we can sometimes say what the cause is. There might be some fetal exposure. I'll say a little bit about that. There might be a chromosomal condition. There might be a more specific genetic condition. I'll highlight a couple of those. And being a twin, well, I'll talk a bit about that as well. And as I said, we really are leaving the majority of children with this esophageal atresia or TOF without an explanation, which as a clinical geneticist frustrates me. So our role as clinical geneticists is to provide information about conditions and what causes them and what the chance of them happening again in a family might be. Just a brief aside is that we're not, of course, if you're a pediatric surgeon, then the anatomical type of esophageal atresia or TOF is very important to understand. But from the point of view of someone like me interested in studying the causes, it's not really possible to match the type of TOF with the cause. So that's all I'll say about that. In terms of early development, some of you might be surprised at how incredibly early in the life of the developing embryo the trachea and esophagus start to form. So what happens is you have this gut tube and this respiratory diverticulum, which will eventually form the lungs, starts to grow between about 4 and 8 weeks, well, really about 3 weeks of embryonic life. So if we're talking 4 weeks from embryonic life, that's 6 weeks from the last menstrual period. So a very early stage when the embryo is tiny, 1 to 2 millimeters, about the size of a pinhead. And the point I want to make is that factors that may have happened in pregnancy that people might feel are relevant. If they occur after this time, they can't be relevant. So that could be a glass of wine that you had that you felt you shouldn't have had, or a tablet, some exposure to some chemical or paint or whatever. If that happened after about 10 weeks, it's not possible. And actually one that I've encountered more than once is trauma as well. So any kind of abdominal trauma, people naturally might worry that that could have upset the development of the embryo. There's very little evidence for that because the embryo is just too small to be affected by any type of trauma. And if it happened, as I say, after 10 weeks, or even probably 6 or 8 weeks, it's not possible for it to be relevant. There's not a lot known about fetal exposures, actually. Possibly alcohol. Certainly, being the child of a diabetic mother, as is well known now, is a risk factor for fetal malformations. Some drugs, particularly thyroid drugs, but people are aware of this now. And then in the news this year, there's been quite a lot about Primodos. Have people heard about that? It's called a hormonal pregnancy test, and it was prescribed quite a long time ago now. So it's a big issue for mums who are 60, 70 years of age, who've got grown-up children, various types of handicap. But I mention it because it has been, as I say, in the news a fair amount recently, and people are trying to establish a link between Primodos, and there is some evidence for a link between Primodos and VACTERL, but it's not very strong. So talking about twins, it's been known for quite a while that being a twin is a risk factor for a really very broad range of congenital malformations, which means any alteration to the expected developmental form of an internal organ of the body. And so all organs are at risk of kinds of developmental malformation. And certainly there's some evidence for esophageal atresia and TOF. So if you look in the normal population, about 1 to 2.5% are twins. And if you look at infants who have esophageal atresia or TOF, significantly more of them are twins. So there's probably quite a few twins in the audience. And the interesting thing about twins is when people think about twins, they usually think, oh, it's probably some kind of genetic factor. But when you look at what's called the twin concordance rate, it's very low. So what's the concordance rate? Well, if twins are concordant, it means that both of them have the condition in question. So if you have two members of a twin pair and both of them have got esophageal atresia, they would be concordant twins. If only one of them has it, they are called discordant twins. And the other factor for which there's indirect evidence, but which is interesting, is that when you look at the type of twin, so you can have monozygotic or dizygotic twins. Monozygotic are genetically identical. Dizygotic are like brother and sister. And the incidence of monozygotic twins is higher than expected. And people have used whether they're like-sexed as a sort of proxy for that. So if all the twins affected by OA-TOF were dizygotic, you'd expect about half of them to be like-sexed and about half of them to be opposite-sexed. But in fact, you find that a much higher proportion than expected are like-sexed. So what can we conclude from this? Being a twin is a risk factor, especially if you're an identical twin, but it doesn't seem to be due to genetic factors. There's something else about being a twin that's a risk factor. And for monozygotic twins, the way that they develop is different from dizygotic twins. So monozygotic twins start off as a single embryo, which splits in two later on during the development of that embryo, whereas dizygotic twins always start off as two separate developing embryos. So maybe it's the process of splitting of that embryo that's responsible in some way for the increased risk of congenital malformations. So just a brief word about chromosomal conditions. So these do account for a proportion of children with esophageal atresia and TOF, but it's nearly always in association with quite a large number of other factors of other congenital malformations or other problems to do with growth and development. So they're quite easy to diagnose, obviously, because there are many different issues with the child, and you can do a chromosome test and figure out what's going on. There's a few single gene conditions. So we all have about 20,000 genes, and they're all concerned with the development of the embryo and physical makeup. And a really small proportion of children with esophageal atresia TOF have got a single gene condition. It's important to know about them because they can run in families, so there could be an issue with recurrence risk. And they can be associated with other clinical problems that are reasonably well defined. So we talk about syndrome when there are other things going on, such as a heart malformation, for example, or a kidney malformation. And if you're concerned about this, and in general, if you want to have advice about what's the underlying cause of TOF in your child, you feel that there might be other issues to do with the child's growth or development or health, or that might be an issue to do with recurrence, and you want to know what the chance of having a second affected child is, which is an issue for some parents without question, then you can ask to be referred to your local clinical genetics service. And there are about 20 or so regional clinical genetic services in the UK. The one that I'm in is based in Exeter and covers Devon and Cornwall. There's one in Manchester, there's one in Liverpool. There are, as I say, and the whole of the UK is covered by clinical genetics services. And you can ask your GP to refer you. And if you really want to make sure that he or she gets it, just say you want to talk about recurrence risk. And whenever you say recurrence risk, the sort of penny drops and they go, oh yes, you need to see a clinical geneticist. But if you're having any difficulty in being referred, then contact me via the TOFS office and I'll try and help out. But usually this should not be an issue. But just to mention very briefly a couple of these, we need to stop at about 22, don't we? Yeah. Feingold syndrome is due to faults or spelling mistakes in this gene called MYC-N. And children with it can have esophageal or duodenal atresia. There can be small head size, there can be learning difficulties, there can be an unusual pattern in the fingers and toes. So sort of incurving of the fingers here or fused toes can be a feature of it. There may also be heart and kidney malformations, and it's dominantly inherited, so it can pass down through the generation. But the likelihood that any given child would have esophageal atresia in a family affected by Feingold syndrome is not 100%. It's more like about 20 or 25%. So this is certainly a condition for which we'd recommend evaluation by a clinical geneticist, and we could provide advice. Charge syndrome is another one that is reasonably well known by non-geneticists. It's an acronym for these various different things that can happen. The gene has been identified. Testing is possible. Sometimes they can have a slightly unusual appearance, particularly with the ears being somewhat cup-shaped, as is described by geneticists. And genetic testing is possible. A few other really rare ones. This condition, mandibulofacial dysostosis with microcephaly due to faults in that gene. This is a really, really rare one that actually I was involved in identifying the involvement of this gene, FOXF1, with some support from TOFS to do that project. That was really good. And then this one here, ANOF, this is really rare and really severe, obviously, because as well as esophageal atresia, the children are born actually without eyes, which is a major malformation, and there can be genital anomalies as well. So fortunately, all of these things are incredibly rare, but they do happen. You know, I've seen families with all of these things, and it's hard. In terms of recurrence risk, this was an interesting study that was carried out by Cedric Carter, who was based at Great Ormond Street Hospital. He's one of the fathers of our specialty, clinical genetics. And when all the first children with esophageal atresia had grown up and were actually in a position to have their own children, which had obviously never happened before because they didn't survive, he wanted to ask the question of how many of those children had children who also had esophageal atresia, which is a very reasonable question to ask. And it turned out actually that the chance of that happening was very low indeed, less than 1%. So, and this is what we find in practice, is it does not seem to be that genetic. And in fact, the one family reported in this paper, there were 3 individuals in that family with esophageal atresia and a couple of other things, and it looks really like a family with Feingold syndrome to me. So if you take out all those families with an inherited condition, it's even lower. It's probably much lower than 1%. So the 1% is a very sort of general recurrence risk figure. So VACTERL association again, another acronym. And what is interesting to me about, I see quite a few children with VACTERL association, and it's in its most kind of florid form with all of these malformations occurring. It's striking to me that you have all these malformations, but in terms of the development and the ability to learn cognitive functioning in school and growth, all these things seem to be fine. So and that's not what you tend to see with genetic conditions, syndrome conditions. I think the recurrence is very unusual, again, so you virtually never see recurrence in the family of VACTERL association. But we really don't know what causes it, so it's mysterious. And I do wonder if the twin factor is relevant here. So lost or vanished twin is something that I know many of you will know about, because we carried out a survey of the TOFS membership, which Sue Lewis-Jones was instrumental in helping to set up, which was interesting. So I've talked about twinning being a risk factor for TOF. But what about a twin lost early in pregnancy? And you can imagine that if a twin is a relevant factor, then you could start off with twins. But if one of the twins, for some reason, miscarried, was lost, died, what you would end up with was just a singleton pregnancy. And the previous twin might not be appreciated, might not be known about. And there is some evidence, not specifically for esophageal atresia, but for malformations in general, that a lost twin is a risk factor for those. And actually, there are some data to show that it's quite a significant risk factor. And that if there is a lost twin in early pregnancy, as many as 10% of children will have, who are the surviving twin, will have some kind of congenital malformation. So we carried out a survey just to ask about this, and we asked about using an early significant bleed in pregnancy as a proxy for a lost twin, which it turns out is probably not a very good proxy, actually, because bleeding in early pregnancy is quite common. But we also asked about whether anyone was actually told that there was a lost twin, because you can sometimes see the empty sac on an ultrasound scan. And we asked about a bit about family history of twins as well. And as an outcome of that, I've been in touch with a number of mums of TOF children, which has been really interesting, who've contacted me to say it wasn't just a bleed, there were other reasons to think there might have been a lost twin, such as presence of a sac on the scan. And also, I've got this family history of twinning, because twinning can run in families. It's a reasonably well-established fact. And so following on from that, I'll say a bit more on subsequent slides, actually. That's probably the easiest. So that's the survey. And I've pretty much been through and it's been helpful in raising awareness of the issue. And I think there have been articles about it in Chew and stuff on the Facebook site about this. So hopefully people are aware that this is something that TOFS and I are interested in looking into. So what I'd like to do as a sort of follow-on from that is to write an article for a medical journal highlighting this issue, which will be a case series. And at the moment, I've got about 8 mums who have contacted me and given me consent to look in their medical records and to write up a short narrative about what happened in each pregnancy, just to draw attention to this possibility. And what I'm looking for this case series is reasonably good grounds for believing that an early twin was lost. So there could be an empty fetal sac, there could be a strong family history of twinning, and ideally no other factors that could point to an underlying cause. So I say 8 people have gotten in touch with me and given consent, and there is room for more. So if people in the audience listening feel that they might be suitable to participate in this and would like to, and of course any publication would not contain any personal information in it, it would all be removed. The only closing date really is submission of the manuscript, and that is still some way off. But what this needs for me is interesting in that, as I said, you get taken in unexpected directions sometimes. And this is certainly not my comfort zone, this area of medicine. And I do need to work with a fetal medicine specialist. So I've been in touch with a guy called Baski Thilanagatham, who is a fetal medicine specialist at St George's Hospital in London, and I've had a meeting with him, and I've got his interest, and we've written a joint proposal to a research group in Denmark. And this is following on from what Matthew was saying about national data. We don't have the level of detail of data that we need to do the study in the UK. But there is this thing called the Danish Fetal Medicine Database that's been running since about 2011, which is, I think, is a wonderful project because they are collecting really detailed antenatal information across the entire population of Denmark and putting it into a single database. And this database has been used in a number of research collaborations which have been published, and I think it would be an excellent resource for us to make. So this is a list of all the things that they're collecting, whether or not it's a singleton pregnancy. And because of advances in fetal scanning, this is a key point as well. It's possible to detect twins earlier and earlier in pregnancy, and that's what we want to do. We want to identify all those pregnancies that were twin pregnancies from as close to the point of conception as possible, so that we can then work out how many of those the outcome was a lost twin. And then we want to know if there was a postnatally diagnosed anomaly. And we need that group, and we need a control group, and then we need careful data on whether this lost twin resulted in the birth of a child with esophageal atresia specifically, perhaps more generally, what the overall incidence of any congenital malformation was. So that is a project that I'm very keen to pursue, and I'm going to talk to Graham over coffee about perhaps what possible involvement in TOFs there could be in that. So thanks again for your attention. Happy to answer any questions. Thanks to Sue Lewis-Jones for her help with that twin survey. Thanks to all the TOFs committee for inviting me and for past support. And if you would like to talk to me about any of this, please drop a note to the TOFS office. They will pass it on to me, and I'll be happy to respond to any questions. Thank you.